Oh, sorry. Okay, so that should work a lot better since now the microphone is actually on. So my name is Monica Parks. I'm one of the third-year cardiology fellows. I'm a clinical fellow, joining a private practice in San Diego after graduation. So for my research talk, I was just going to kind of do a quick run through and kind of summarize some of the projects that I basically spent this year finishing up in preparation of graduation. So we'll start off first by talking about a project I'm finishing up over here based at our local VA, working with my co-and Paul Hess for patient symptoms and stress testing after elective PCI in the Veterans Affairs healthcare system. Oh, sorry. Yes. Perfect. So as background for this paper, one thing I want to make is that stress testing is something that's very commonly overordered. And when patients have undergone PCIs or any kind of coronary intervention, generally speaking, these patients do not routinely require stress testing in the first 3 years following their coronary intervention, unless there are concerning symptoms or some other clinical change. So one thing that we want to look at was within our VA healthcare system, how many of these tests are we actually ordering? Are they being ordered appropriately or not? Meaning, are we ordering them just routinely, just for the heck of it, because the patient had a stent put in? Or are we actually ordering them appropriately because the patient has had symptoms or some other clinical change that may make that stress test useful for them? So looking at our total study periods, this was done over a course of about 3 years, we're able to basically look at a national level at the VA and collect everybody who had had a PCI and subsequently stress testing. So in total, we had about 795 cases of people who had both undergone PCI as well as stress testing. And the demographics I'll point out here, there's a pretty typical VA population. So the vast majority are male. I think we only had a handful of women in this study. The vast majority are also white. Looking at their initial PCI event, and this was generally, we excluded those who had undergone PCI for acute coronary syndrome. These were people who had undergone elective PCI. In general, we found that the majority of them had one vessel obstructive disease, but there were smaller percentages that had multi-vessel disease or just completely non-obstructive disease. Looking at their comorbidities are pretty much what we expect: a lot of hypertension, hyperlipidemia, diabetes, family history, heart failure. And what we pointed out here, so we basically took these patients and looked at all those who underwent elective PCI, and then looked at those who underwent stress testing within the 3 years following that event. And that could be any kind of stress test, could be nuclear stress testing, echo stress testing, treadmill stress testing. And what we found is that, at least looking at this, we then did a chart review to see which ones actually had symptoms or no symptoms. And we found that the vast majority of these patients actually did report symptoms during their follow-up clinical follow-up that merited the stress testing. About 92% of them had chest pain, shortness of breath, lightheadedness, basically symptoms that could suggest coronary ischemia following their PCI event, and therefore potentially meriting stress testing. In terms of the actual results of the stress testing, as you can see, the vast majority of these stress tests were actually nuclear SPECT stress testing, with the smaller percentages getting exercise testing, meaning treadmill testing, stress echo, and maybe only like 1 or 2 actual CMR testing. In terms of the symptoms that they endorsed, the vast majority of them were chest pain as well as dyspnea, which are fairly typical symptoms of coronary artery ischemia and things that we were looking for in our charts. In terms of the actual stress test results, it was a little bit split. About half of them were negative, half were positive, and then smaller percentages were equivocal or indeterminate, and we're able to obtain the stress testing results for most of these. And as you can see, general breaking them down by those with symptoms or without symptoms, there actually wasn't a big difference in terms of which ones were more likely to have a positive stress test within those 3 years following their PCI, kind of interestingly. We also tended to break this down because this is really sort of a quality improvement study. So looking at the order of appropriate stress testing, meaning stress tests ordered for symptoms, did it vary a lot by site. So the limitation here was that most sites only ordered a handful of studies, like 3 to 5 studies. So it's a lot of variation in terms of our spread. But breaking this out, so our Y-axis here is the proportion of stress testing that was ordered among symptomatic patients, meaning appropriately ordered. And then our x-axis here is basically spread out by site. And as you can see, there wasn't a whole lot of variation. And because each site only ordered a handful of studies, a lot of these are really spread out over a number of sites. It was a little bit difficult to really point out any significant trend. But the point being that there also were not a lot of significant outliers here. We also looked to see, was there any change in the terms of the cumulative incidence of the stress testing that we were seeing post-PCI, meaning was it more likely to happen at, let's say, a year out from their PCI, suggesting that, oh, they're doing a 1-year follow-up and then they're just ordering a stress test kind of willy-nilly at that visit? Or was there any other clear pattern? And here you can see it's basically just a broad cumulative incidence of stress testing over time, suggesting that these tests, as we saw with how many of them were being ordered for those with symptoms, that these were being ordered essentially whenever these patients presented for clinical care or endorsing symptoms that potentially merited post-PCI stress testing, versus people were just kind of automatically ordering them at 6-month or a 12-month follow-up. So our takeaways from this, kind of interestingly, was that over the study period that we looked at this, in total, only about 25% actually underwent stress testing in that early post-PCI period. The vast majority of these patients actually did have symptoms such as chest pain or dyspnea that suggested that they did have recurrent obstructive coronary artery disease. So the vast majority of these are actually being ordered appropriately post-PCI. We saw that there is minimal site-level variation in the proportion of stress tests that are prompted by patient symptoms. So overall, although the context for this is that there are concerns that there are a lot of inappropriate early post-PCI stress tests being ordered, at least within the VA system, we didn't see as much of that. Now, you can make a lot of arguments about this because the VA system is its own discrete healthcare system and behaves in a lot of ways very differently from private systems, where perhaps there might be different reimbursement structures or different incentives for ordering certain types of stress tests or ordering them early or inappropriately in certain patients. But at least what we saw in our VA system was that this was actually a pretty reassuring study, in that at least within this type of healthcare system, the vast majority of tests were being ordered appropriately for patients with symptoms. And that said, that doesn't necessarily extrapolate to other healthcare symptoms, or other healthcare systems. So something just to pay attention to. But I thought kind of an interesting exploration of at least how we're behaving within our VA healthcare system. We published this in JAMA Cardiology, and I think was a pretty interesting addition to the literature about general quality improvement and general examining of our current clinical practices. So that was one project that was finished up this year and then published. And then just to mention another smaller project that I was finishing with some collaborators over at my old residency in UCSF, primarily working with Dr. Nelson Schiller, who's primarily involved in echo. We're basically, for this project, just looking at echo markers and just thinking about other ways that you can utilize the imaging that we obtain from our echocardiograms. So the focus of this project was about looking at left and right atrial size ratio to identify left atrial enlargement. So the context for this study is that left atrial enlargement, this is the chamber receiving blood, generally it's actually a pretty good prognostic marker for our clinical management of patients. If we see left atrial enlargement, it predicts incidence of atrial fibrillation. It predicts the risk of developing left ventricular dysfunction, stroke, even long-term cardiovascular and overall mortality. So although we see this a lot, and often we kind of glance over it, it actually is a very important prognostic marker. And if you see it in your patient's echo, that can make you think this patient might be a little bit higher risk for developing clinical complications down the road. Our current American Society of Echocardiography guidelines define our ranges as normal from 16 to 34, and then mild, moderate, and then severely abnormal. And these guidelines came out in about 2014. So one thing that we wanted to look at was just, these were actually relatively recent guidelines, and a lot of practitioners out in the community actually still use our old guidelines, which were a little bit more liberal in terms of when we define something as being abnormal. So we wanted to say, is there any other marker that we can use, for example, the size ratio, to identify or predict left atrial enlargement? So for this study, we used data from the Health eHeart protocol. So this was basically a protocol that took EKGs, treadmill, and echo data on a population of completely healthy people. So we took echo data from these folks, and we took about 108 of them. And we basically went through all their echoes and measured their left atrial to right atrial size ratio. And we used that to define our normal parameter using these healthy subjects. We defined that on 3D echo as 1.07 centimeters as a ratio versus 1.05 as the biplane to single plane ratio. Now that we defined our healthy sort of parameter, we then applied it retrospectively to a series of 99 clinical studies who in their echo reports had documented borderline or mild left atrial enlargement. All these studies were obtained from our imaging center over at UCSF, so a single academic imaging center. So we took basically this healthy number and then applied it back to a series of 99 studies with presumably unhealthy hearts because they identified left atrial enlargement, just to see if we could validate that size ratio against already identified left atrial enlargement on these echoes. So in terms of our basic demographic population for our series of 99 patients with unhealthy hearts, about half were borderline and half were mild left atrial enlargement, about half were male. Generally, we saw like relatively low. So for the borderline left atrial enlargement, the volume index was about 31, which is kind of borderline to mild. And then for our mild, it was about 38. And then we calculated our left atrial to right atrial ratio in this population and found that it was elevated in this group. A couple other incidental findings, but nothing else that was very significant, a little bit of MR, some diastolic dysfunction. Overall, these were generally echoes that were mildly abnormal with just a little bit of left atrial enlargement. This is an example of just how we actually take how we actually obtain these measurements. So it's a biplane measurement looking at our 4-chamber view and then looking at our 2-chamber view to look at our left atrial size. And we calculated the left atrial to right atrial size ratio from the 4-chamber view, which is generally our standard measurement for looking at both of these. And then just looking at these, we just wanted to see, could we use that size ratio and was it significantly associated with left atrial enlargement in that normal healthy population from healthy heart versus these patients who had borderline to mild left atrial enlargement. And it wasn't terribly significant, but we did see that there was some linear correlation there between increasing left to right atrial size ratio and developing borderline or mild left atrial enlargement. So the takeaway from this one was that, yes, we could use this as another marker to help identify left atrial enlargement in these abnormal subjects compared to normal healthy ones. And we sort of consider this as potentially this is something that you could use if you're looking at someone's echo and thinking, is their left atrium enlarged or not? Potentially that'd be another marker to say they're probably going to develop this over time, or this is something that already exists. And like I mentioned, there is some prognostic value to that marker. So it's basically another way of looking at these studies and just saying, is this another piece of data that we can gather from our available echo data to potentially identify patients who are at greater risk of some of these cardiovascular complications that we talked about? So that is pretty much it. So that's a pretty lightning quick run through in terms of a couple of projects that were finished up. This one is also finished and presented at ASC this year, and then currently is in the works for publication. And I think that's about all I had for you guys. Any questions about either one of these two projects?
Yes, I have one question, although I'm not sure you looked at this in outcomes, but there's kind of some interesting literature on right atrial enlargement predicting response to people who have persistent AFib and sort of ability to maintain sinus rhythm. And there's a sort of theory that if the right atrium is normally sized, you have a higher likelihood, regardless of the left. I don't know, did you guys look at any sort of prospective outcomes in terms of like AFib recurrence or anything like that?
Not for this one. That'll be the follow-up project from this one after we have a few more years of data on that unhealthy population to see if there is a prediction there. But that is a good point that historically the right atrium is a little bit under-examined on a lot of echo studies. We don't even have a great way of rigorously examining right atrial size. The current ASA guideline for it is to take essentially a single 4-chamber view, get the area and the length, 21 for women, 25 for men, and then that's about it. So that is a good point that potentially some of these other atrial measurements are something that we're realizing that there's prognostic significance for them, and we should be paying more attention and maybe more rigorously examining them when we actually read these patients' echoes. So I think that's something we'll probably see more of in the future.
Hi, Monica. Very good. So I have a question concerning the first study that you did. So it seems that the VIA is doing a great job.
Yeah.
But the question is why there is this discrepancy. So what is the driving problem for the other institutions? So for instance, they miss order because of economical factor, because of they don't order appropriately. So what do you think?
So there's a lot of theories about that and other studies. I didn't show these, but when we have examined that question in other healthcare systems, you'll notice that there's sort of spikes in ordering of these stress tests at 6 months and a year, suggesting they're doing them routinely. So is it a force of habit? Certainly compensation models in other healthcare systems are very different from the VA, so presumably there is some motivation there, whether that's explicitly or sort of on a subconscious level in some areas. So it's a good question, and our thought right now is that it's because of the way reimbursement and the way government healthcare systems are structured versus a prior practice where it's a more fee-for-service type of model. You're the stress test, you get paid for the stress test, right? But it's a good question, and it makes you realize that if you're going to be concerned about something like we're ordering too many stress tests, or there's too many casts, or there's too whatever, you have to put it in the context of the healthcare system that you're examining and realize that healthcare provider behaviors vary quite a bit, not just on the individual level, but depending on the system they're working in. It'd be interesting to see what happens at the university hospital, especially since it's actually recently, in the past week, there's a QI project out here at the university. Apparently our no-show rate for stress tests here is about 40% or so. So it raises a specter of what is our behaviors here in terms of how are we managing these types of testing? Are we educating patients appropriately? And are we even ordering them appropriately? So it'd be interesting to repeat the study based at the university and see what happens here. But a really great question.
Excellent.
Yep. All right. Anything else? All right, great. Well, I'll turn things over to Santo then. Here you go. It's open. Here.
Excellent. Is that working? Okay. Excellent. Thanks for attending, everybody, and supporting Monica and me. My name is Santo Ricceri. I'm one of the third-year cardiology fellows here who will be departing next year. And I'm going to jump right in here. The title of my talk is Atrial Isochronal Late Activation Mapping. And we're going to get into a case report that I have that I will be presenting at HRS this year and hopefully submitting for publication. So I'm going to start out with a disclaimer that this is a world that I don't live in every day. So I'm not an expert in mapping, but I'm going to try to take you through some of the concepts behind this isochronal late activation mapping. And to do that, I'm going to start with some background. So there's a lot of text here, but the question I'm trying to answer is what is isochronal late activation mapping, which I will refer to as ILAM at periods. So in the normal myocardium, there's uniform, or relatively uniform propagation of electrical impulses across the heart. However, regions of abnormal myocardium may have late activation due to impeded electrical conduction due to abnormal cells, right? And so this would create a zone of deceleration where signals that are traveling slow down when they hit this impedance. And those same zones are high risk for setting up arrhythmias like reentrant tachycardias. And so isochronal mapping is a technique that's used to visualize the timing of electrical activation during normal sinus rhythm, which is important, and we'll get to in a second. In order to do this effectively, you have to have very high density mapping catheters that allow you to get very granular data on the cardiac myocardium and give you the ability to watch these signals as they propagate over a cardiac cycle. And this data is all compiled by sweeping a catheter across whatever part of the heart you're interested in, and then creating a map with these isochrones. And isochrones are just areas of similar activation times across the myocardium. So I'll show you a picture of that in a second, but just an example here of one of these high density mapping catheters that are required to gather this data. So this is like a very expensive fly swatter that has 48 electrodes on it over these splines that you can see here. And this allows you to get directional activation data and map with a high level of fidelity across the myocardium, whether that be atrial or ventricular. And here is an example of what one of these maps might look like. This is a representation of the left ventricle that has been mapped using this ILAM technique. So the white zone is more anterior, and this shows the propagation of the electrical signals from anterior to posterior, and these arrows here are the direction that the signals are traveling, and each one of these 8 colors represents an isochrone. So this is relatively similar activation times within this red zone, and then within this orange zone, yellow, and so on and so forth. But you can see here that the signal starts to get bunched up, and this is what one of those deceleration zones look like. And to define that, this is where you have more than 3 or more isochrones in one 1 centimeter voxel. So when you have a lot of colors crowding together, that is a point at which the signals are decelerating and moving slowly, and that is an area of interest for anybody trying to ablate a reentrant tachycardia. So how is this different from conventional bipolar mapping? So I think in order to understand the benefits of this technique, we have to also understand what is normally done during an ablation. So bipolar mapping generally provides both a voltage map that identifies areas of normal and abnormal tissue, and that's this map that you see here on the left, with areas that are red having very low voltage, likely representing scar, and areas that are purple having high voltage, representing normal tissue, and then various shades of tissue in between. And then on the right, you have activation mapping. So this mapping is typically done during the tachycardia that you're interested in studying, and shows the activation pattern of this tachycardia. So here, the signal is starting in the red, which is the earliest activation zone, and moving outward from there. And we'll get back to both of these maps in just a bit. And then on the far right, I've provided a couple of examples of bipolar mapping catheters that obviously have less electrodes and provide less granular data than the high density mapping catheter I showed you earlier. So when is ILAM used? Why might one use ILAM? So this is a very useful technique when you're trying to study a hemodynamically unstable rhythm, right? You can map this during sinus rhythm. They don't need to be in the ventricular tachycardia to obtain this data. So there's a significant safety advantage to using this technique. And it's in fact becoming the mainstay of ablation strategy for scar-related ventricular tachycardia. You can find these zones during sinus rhythm, ablate them, and have success doing so without inducing a hemodynamically unstable VT. And there is a lot of literature out there showing that these areas of isochronal crowding or deceleration zones during sinus rhythm correlate very well with the critical isthmus of a ventricular tachycardia, that is reentrant and requires this isthmus to exist and perpetuate. However, the use of this technique in the atria is less well described. Atrial arrhythmias are generally very hemodynamically stable. It is possible to perform mapping while someone is in one of these arrhythmias throughout the case. So it's less critical from a hemodynamic perspective, but there may be some advantages still to using this technique in the atria. And we'll get into one example here in a second. And just to show you a little additional information on the ventricular tachycardia mapping. So looking at that same map we talked about earlier, where there's this clear area of isochronal crowding, deceleration of the electrical impulses moving through this zone. So when they went to that spot in the myocardium and paced, as you'll see over here in this pace map, they get the exact same electrocardiogram as they saw in ventricular tachycardia, meaning that pacing in this area is where that VT was coming from. So this is a critical part of that ventricular tachycardia. So this is just sort of proof of that concept, that this is a critical part of this ventricular tachycardia. And then down here in this D panel, I think it's a nice picture just to show how many points are obtained during the mapping. All those yellow dots are individual points for which they have data of how the electrical signals are moving. So it is quite granular. I think that's a nice visualization of that. So is this useful in atrial mapping? What might be some scenarios where this technique can be used during atrial arrhythmias? So we'll jump into a case here where hopefully I can show a scenario where this might be useful. So this is the case report. This is a case of a 27-year-old woman. She has a history of detransposition of the great arteries. She had an arterial switch procedure, a VSD repair, pulmonary valve replacement, and a typical atrial flutter ablation in the past. So she, and I included this picture here just to show how much goes into one of these arterial switch operations, how much scar she must have in her myocardium is the point here. This is somebody who's at high risk of having arrhythmias in her atria. And she developed another supraventricular tachycardia and was referred for catheter ablation. So I'm going to start here with the conventional mapping of the left atria. So we saw the sort of bullet-shaped left ventricle earlier. This is the a picture of the atria here, specifically the right atria, and those are your SVC and IVC that you're seeing. And the black dots here represent phrenic nerve capture, which is going to be important. The map on the left is the voltage map of the left atria, with red representing low voltage, likely scar, again, purple representing normal tissue, and then the other colors, somewhere in between. So she has a lot of scar in her right atrium, and on the right, you'll see the activation map. So this was a map created during the atrial arrhythmia that we are interested in ablating. And you'll see that there's early activation. So this is the red part of this right image. This is where the earliest activation is happening, and it's spreading out from there. So this is clearly a critical part of this atrial arrhythmia, but it lies right over the phrenic nerve, which is the black dots here. So ablating in this instance might cause damage to the phrenic nerve and issues down the road for her from a respiratory perspective. It's also worth pointing out that this activation map does not give us the mechanism of this tachycardia. It just is showing where it's starting and how it's spreading out. So we don't know if this is an ectopic atrial arrhythmia like an atrial tachycardia or a micro reentrant tachycardia based on these maps. So the decision at this point was made to try atrial isochronal late activation mapping. So if we gather all this granular data and look at the isochrones, might this provide another area of interest that potentially could be ablated and terminate this atrial arrhythmia without damaging the phrenic nerve? So you'll see on the ILAM map on the left of the screen that there is this area of clear isochronal crowding that is away from the phrenic nerve. And it's near the site of early activation, which suggests that it may be a part of a reentrant rhythm. It is close enough for sort of micro flutter. And here again is the bipolar voltage map on the right, showing this area has some myocardium that is not scar in it. So the decision was made to ablate this area of isochronal crowding. After the ablation, the arrhythmia was unable to be induced again. So again, kind of proving that this was likely a critical component of a reentrant atrial arrhythmia that relied on this section of myocardium identified by the isochronal late activation mapping, and that ultimately allowed ablation distal to the phrenic nerve and avoided injury of the phrenic nerve. So the conclusion of this case, at least from a patient perspective, is that she has remained free of any atrial arrhythmias. It's been 6 months since this ablation, and she has intact phrenic nerve function. So it seems like, for all intents and purposes, that this was a successful ablation and a successful use of this isochronal late activation mapping technique to enhance the safety of an ablation procedure. In terms of the science, isochronal late activation mapping, I think, is an interesting tool to use in patients with complex congenital heart disease because they have a high burden of atrial arrhythmias. They have complex scars. They don't tolerate these rhythms well. And there is a well-defined benefit of ablation in this population. So this may be a good population to use this technique on, especially when you're near critical structures like the phrenic nerve. And application of ILAM within the atrial substrate in sinus rhythm, I'm kind of reiterating this point, particularly for those with congenital heart disease, may have potential to improve both the atrial arrhythmia recurrence rates and the safety. Here is the poster that I will be presenting at HRS in a week, I guess, a little over a week. So if anybody has any help with improving the poster, that would be appreciated. I'd like to thank everybody who collaborated with me. Neet Sandhu, who's here, was a part of this case. Thank you, Neet, and Ryan Alliong has helped a lot, Chris Barrett, and really the entire division of electrophysiology here at the university has been instrumental in putting this case together and getting it to HRS. So thank you, everybody. And this is my dog, Benji.
A great presentation and congratulations on your abstract.
Thank you.
I have a question. So I understand that this technique increases the specificity and the accuracy of the ablation and the mapping. how it increases the safety, which seems to be also the case.
Yeah, I think it provides potentially additional areas that one could ablate. So if you are doing traditional mapping and find that the area that would make the most sense to ablate is near a critical structure, you can kind of use this technique as a backup to identify potential other areas where you can avoid those critical structures. So yeah, more of a safety in that regard, that you just have more options.
I think that when we use that was a nice review of a lot of very important EP concepts that I think are difficult and but things we use every day. So when we're ablating VT, for instance, you know, I think there's a few different potential strategies for VT ablation, and Santo touched on some of these. But if you have a hemodynamically tolerated VT, then you can map in VT and you can define the arrhythmia circuit. But a lot of times, as he said, we don't have that luxury. And so we're looking in sinus rhythm, can we identify where the critical elements of the arrhythmia circuit or circuits could be? And I think over the years, we've had lots of different iterations on how we approach ablation and the ablation targets and strategy in sinus rhythm. You could ablate the entire substrate. So if somebody's had an LAD territory infarct, you could ablate around the perimeter, the border zone of the entire scar, as well as measured electrograms within the scar. And the idea that being that you are trying to close all the potential doors of the entry and exit of VT. But that can be a very long procedure and carry some morbidity. So from a safety standpoint, it would be great if we could focus on our efforts on the areas that are most important for VT. And so, you know, I think when you're doing a map in sinus rhythm, you can tag areas of late potentials in sinus rhythm, and that may get you into the neighborhood. But I like this analogy that Rod Tung, who you know, I came up with this sort of concept that when he was at UCLA makes sometimes, and that would be, you know, if we're doing an activation map and I compare it to my arrival to work, if I'm late to work, the latest point would be because I was slow coming in from the parking garage, but that might not have been the bottleneck or the zone of slow conduction. Could have been I took too long of a shower, or I took too long getting dressed, or we got stuck in traffic. So we're trying to identify where the deceleration zones are in sinus rhythm, and this technique really is doing that by looking at where the colors crowd together, the isochronal crowding. So I guess the long-winded answer, I think, to that question is it allows us to potentially focus our efforts in the most critical areas of substrate in a targeted fashion, and potentially shorten procedures in patients that are otherwise very sick. So.
Yeah, and there are other projects ongoing here that I'm not a part of, but looking at this atrial ILAM technique to, you know, potentially find patients who are at high risk of developing typical atrial flutter after you do an AFib ablation. So if on your way out you can do this map and say, oh, this is somebody who is high risk because there's a deceleration zone, maybe we should just ablate the CTI on our way out. You know, that's one thing that Ryan Alliong is looking at. There was a paper published recently in Circ looking at using this technique to guide some parts of AFib ablation. So if there are areas within the atria that look high risk, in addition to the pulmonary vein isolation, you can go after those and see if that works. So there is work being done actively looking at, you know, other ways to use this technique, not just for safety, but for clinical efficacy as well.
So I have a question based on what you guys are discussing, and granted that I am not a clinical person. So everything that I hear in research conference when ablation is mentioned is the issues with specificity and all that. So what is the disadvantage of using this method? Why is it not used more frequently?
Thank you, Nate.
Thought that was really nice and nice review of a complex topic. I think just briefly, the field with arrhythmias, in particular micro-reentrant arrhythmias, the mapping, activation mapping is based on what we call the exit site. So you can map in time as to where that exit is based on the morphology of your VT or your atrial tachycardia. And often that site is where the global myocardium is being captured as reflected by your surface ECG, but the elements that propagate that arrhythmia are somewhere else. So this is, it's been around since 2015, really in practice since 2018, and it's one of the nice ways to see where is this arrhythmia coming from, despite the fact that it's exiting somewhere else. More commonly, yeah. It really, the foothold for it at the moment is VT ablation, where for the reasons Matt mentioned, that we don't really get the luxury of often understanding VT because it's often unstable. And then in other areas like the atrium, where you might have a lot of scar, like this person with congenital heart disease who's had multiple surgeries, this sort of technique is being studied and can be really useful. On the other hand, if you have a relatively normal atrium, you can often understand this macro-reentrant tachycardia, or perhaps a focal one, quite clearly because there's no scar just to provide additional substrate.
There's two endpoints. I mean, I would argue that this is the type of thing like AI would be perfect for, to tell you, not only creating the map, which I think it's still manual, right? The mappers still have to, it's partially like sort of semi-automated.
Otherwise, it used to be that you list one map.
Yeah. But which there's still, even if it's automated, there's still issues with split potentials and things. But there's two parts to this. One is the circuit you're seeing in the lab, and can you define that? And is that, can you ablate it, which would get rid of it, depending, this is one strategy. It doesn't necessarily predict whether they're going to have other circuits, other arrhythmias, and particularly in atrial myopathies. I mean, the process that led to this scarring continues. It's not like ablation's disrupting that. And so, a lot of us, would like to see not only the, case reports of showing that you can terminate with a strategy based on, the mapping, but also that the strategy as a whole leads to reduced recurrence rates, which for a lot of these has not panned out. In fact, the last 15, 20 years of EP is sort of a graveyard of really popular ablation techniques that, when you actually looked at clinical trials, didn't improve outcomes. So I think there's more to be written.
This is really only for pediatry. This doesn't help you at all.
When you say early.
Okay, perfect. That's the kind of feedback I was looking for. Thank you.